It's my pleasure now to introduce tonight's program, and we think that this is a program that is timely, and it's rare you can say that when you have lots of immediate evidence to back it up. On my computer, I have BBC bookmarked on my computer, and on Monday a story popped up to let us know that the CDC had announced that the Zika virus crisis was probably worse than they had imagined. And yesterday at 4 o'clock, another story popped up to say that the first evidence had come in that the CDC was willing to say it looks like there really is a link between birth defects and Zika virus infection. So this is something that is just bursting on the scene, and it's a very, very complex issue, and therefore what better venue than to have some of our experts on the faculty cover it. We were really lucky that we were able to get a moderator tonight who knows of what we speak tonight. Jeremy Smith is a graduate of University of Montana, where he got his master's. His undergraduate degree was from Harvard University. I'm looking at you, Tom. And his book, Epic Measures, which is out in the hall there afterwards, is, I got to tell you, an amazing read. It's gotten fantastic reviews. And to just be clear about it, it's the true story of a 20-year, 500-scientist, $100 million moonshot attempt to track and quantify every illness, injury, and death of everyone on Earth. The biggest big data project ever. And Bill Gates said, Epic Measures is a fantastic read. And then there's about 5 other quotes in here I'm supposed to go. But I'm going to go to a biologist, because this is somebody I really respect. E.O. Wilson, who's a very renowned biological scientist from Harvard, said, Jeremy Smith tells an inspiring story of how a simple idea, conceived logically and pursued with grit, can greatly improve the human condition. Jeremy's a personal friend, and I'm so pleased he's here to do this tonight. He's going to introduce the topic and our speakers. Jeremy?
So we're going to kind of host a little radio show that's not on the radio. So thanks for coming. And sort of fill you in on different experiences, different perspectives from this and sort of past epidemics, infectious disease epidemics, and just sort of how to think about health, how to think about crises, how to think about reproduction, how to think about communication. So I want to get right into it, tell you the wonderful teachers and academics and experts that are on my right. So Joel Iverson, at that end, received his PhD from Arizona State University with a focus on organizational communication. His research interests include organizational knowledge, nonprofit organizations, and risk and crisis communications. And his work has been published in various communication and nonprofit journals, including Management Communication Quarterly, Journal of Applied Communication Research, and Nonprofit Management and Leadership. Now he is an associate professor at the University of Montana, and he's examining the impact of Ebola on U.S. health organizations, risk communication for global earthquake forecasting, and just to mix it up, the enactment of mission for nonprofits, especially in the Bakken oil region of eastern Montana and western North Dakota. So he seemingly knows everything. So we'll
or nothing.
Or nothing. He's a fox or a hedgehog. I'm not sure. Okay. Teresa Sobieschek is director of the International Development Studies and Peace Corps Prep program here on campus, as well as an associate professor in the sociology department, which is probably also confused for other departments sometimes, but not geology, hopefully. She is a social demographer and earned her doctorate in development sociology from Cornell. And she studies international labor migration, marriage migration, which we'll figure out what that is in the course of tonight, fertility decision-making, and access to health care in Southeast Asia, and has lived in Southeast Asia for more than 7 years, mainly in rural Thailand. Her focus is on gender issues related to demography. And finally, closest at hand to me, Steve Lodmell is a biochemist and a molecular virologist who has worked on understanding the molecular basis of viral replication since 1996. After earning his PhD at Brown in 1996, he did postdoc work at the Université Louis Pasteur in Strasbourg, France, studying the structure and function of the HIV-1 RNA genome. Since coming to UM in 1999, his lab has worked on the mechanisms of the control of gene expression in HIV-2 and has worked on understanding the basic molecular mechanisms of replication of another emerging pathogen, Rift Valley fever virus, and has invested effort into developing new targets for antiviral drugs to combat Rift Valley fever virus infection. So, hopefully he will save us all. And so I hope you saved him a cookie from the back. So I'm going to start with just a few short questions in a row to sort of a single panelist, and then I'll kind of open it up to all of them. And I may even have a bonus panelist. So if you get nervous. Okay, so just to begin, Steve, from a lab, I just sort of for a lab scientist perspective, step one, what is the Zika virus?
Zika, so almost everyone in the room has heard about Zika, and certainly in the last month or so. And one of the most notable things about Zika is that it was distinctly notable for several decades. It was first described in 1947. It's named after the experimental forest where it was discovered, the Zika forest, not too far from Entebbe, Uganda. And it was first discovered in a sentinel monkey. That is a monkey, a rhesus macaque monkey that they put in a cage in this forest because they were looking for the presence of yellow fever. And this monkey became ill, and they isolated virus from the monkey, and they named the virus Zika. And the first human cases of Zika were described some years later in the early 50s. And it caused a mild fever, a rash, conjunctivitis perhaps, but it was not a serious enough malady that anyone even considered trying to make a vaccine to it. The virus is related, now we know more about the sort of molecular phylogeny. It's related to dengue virus, it's chikungunya virus, yellow fever virus, so it's got some notable and notorious colleagues in its field. After its discovery in Uganda, some years later, it was determined that about half of the human population in localities in Africa were seropositive for the Zika virus. That means that they had been exposed to it, and there was not a major health crisis, at least none that was reported. But clearly, a lot of people were exposed to it. And then, some years later, probably also in the 50s, it made its way over to Southeast Asia. And we can sort of track the progress of the virus by looking at the molecular signature of the virus, so we can sort of see where it's been. Then more recently, it jumped over into the Pacific Islands, and some of the best data that we've got from an epidemiologic standpoint come from French Polynesia. And the Tahiti it's a French protectorate anyway, and so the medical infrastructure is quite good. And when it moved over to French Polynesia, the medical establishment noticed an uptick in Guillain-Barré syndrome. This is a neurologic syndrome. And a little bit later, some suspicion that there may be an uptick in some birth defects. And so what started as apparently a not very serious virus in Africa is now spreading very rapidly in South America. It's present in 20 or more countries in South and Central America. It's carried by a mosquito that's endemic originally to Africa, but is now spread to a lot of equatorial regions in the world.
Go ahead, please.
And it's spreading northward really quickly. It looks like it got over to Brazil just about a year and a half ago, and it's spreading northward quite quickly.
I was in LAX last week, and there was a very helpful sign at the TSA thing that said, there's this thing called Zika. It was like a government official, so it didn't say there's this thing called, but it said, Zika virus warning, do not get bit by a mosquito.
Right.
Is there a vaccine or other way for people to protect themselves besides not getting bit by a mosquito?
Yeah, not right now. There's no licensed or proven effective vaccine. There is a vaccine against yellow fever virus, and yellow fever virus is related to Zika. It's probable that the strategy used to develop the yellow fever virus could be applicable to Zika, and I'm aware that CDC and NIH and around the world, health authorities are putting vaccine efforts on a fast track right now. Right now, the best thing that you can do is avoid being bitten with insect repellent, mosquito netting. The mosquito that's principally spreading the disease right now is Aedes aegypti, and this mosquito likes to live close to people. You don't even find it far from human habitation. And so the other best thing to do is to eliminate around dwellings places where the mosquito can breed. Any small quantities of standing water are sufficient for these mosquitoes to breed in.
If you're not a pregnant woman, what are the health effects or dangers, or the child, I should say, the would-be child of a pregnant woman?
Right. So this is a big question, and I think the notion of a virus that causes birth defects is something that really impacts us strongly as humans. I mean, it's one of the most scary things that we can imagine, and I think that's one of the reasons that this is such a visible virus. And I note again that this virus has been around for a long time and has not previously posed a serious health threat that we know of. It's possible that it went underreported in Africa. It's possible that as the virus has moved around the world, it's encountered populations of humans that are subtly genetically different and more susceptible to pathologies. And it's also possible the virus has mutated a little bit and it is more pathogenic than it used to be. But currently, there's a low incidence. The best estimates are that maybe 1 in 5 people that are infected with the virus even know it, so that they get some symptoms. And so the 1 in 5, then how serious is the disease? There's a very low incidence of Guillain-Barré syndrome, which is a paralysis, temporary paralysis. It's an attack on the nerve cells. And the most high-profile problem is that a developing fetus could have serious health defects, including microcephaly.
I want to turn to Teresa for sort of a sociologist's perspective on what this kind of outbreak looks like on the ground in an affected community. When you were in Thailand, you lived in a community with an outbreak of dengue, another debilitating viral disease transmitted by mosquitoes. If I understand it right, you correct me if I'm wrong. And where was this? Can you just sort of describe the location?
So a lot of my research when I'm in Thailand is in northern Thailand in remote rural areas. This particular project was on access to healthcare in remote rural areas. So I asked to be in the most remote county of the province, farthest away from medical care and a doctor. And so, of course, I'm out there, and I didn't realize that they had such a problem with dengue fever. But when I got there, they were saying, you need to be really careful of mosquitoes because last year, our village was the highest per capita infection rate of dengue, not just in Thailand, but in all of Southeast Asia. So like, okay, lots of repellent everywhere, So I'm usually pretty careful, but I was very, very careful to avoid being bitten. And indeed, even the community itself was so worried about the disease that they were taking a lot of public health measures that are kind of shocking to someone from America in order to try to combat the potential threat of dengue, which again is carried by the same mosquito as Zika, and is a very common mosquito around human populations like the village.
So who was affected and what were the sort of symptoms? What was the effect?
Yeah, so you don't so much have to worry about microcephaly babies with dengue fever. It's another very high spiked fever. Most people will get the spiked fever. You can also get a rash, but it's called sometimes break joint or break bone fever because it feels like your bones or joints are actually breaking. It's that painful. And then a small proportion of the cases, maybe between 1% and 2%, actually develop a hemorrhagic version of this disease and then actually have vomiting and blood coming out of orifices and death. But the general one is just the break joint thing. So kind of a little bit scary. So I was there studying healthcare, so I happened to get a chance to get involved with some of the other healthcare actions in town. And one of them you can see in the picture above you. I took this picture. It's my next door neighbor's house. But here we are in a poor remote Thai village where household incomes may be something like $250 or $300 per year. And some of them are well below that. That's the average. So it's a very poor community. And yet they went door to door and collected money from the villagers to pay for these guys to come and spray the village because they didn't want to have the risk of dengue since they had such a bad case the year before. It was also kind of interesting. The woman I was living with in her house, she is one of the public health workers of the community. They have what they call village health workers, that if you agreed to be a village health worker for a year, you would be responsible for about 12 households and the health and also some of the statistical recording for those people. And so she was part of that health team, and for that she gets free health care for herself and her family over the course of the year. So it's kind of a volunteer position, but also kind of a little bit paid. And so I got to go with them, and we got all the sixth graders of town, which was the highest level of education available in our village, and open place, very different. You can't imagine this in Missoula, but we went door to door, not only to yards looking for places where mosquitoes could be breeding, to both report it to the health workers, but also to dump the water out. But we even, had permission. We just went into people's houses and went looking around. And, what do you know? You're in the kitchen of someone. Why would you expect standing water in the kitchen? Well, because of ant issues and other insects, they put the legs of cupboards in little bowls of water to prevent ants from crawling up the cupboard and getting into the food. And so, but in those little bowls of water, we could see swimming around the mosquito larvae. So you have to convince them, well, ants are less deadly than the mosquitoes, dump out the water. So just amazing public health action to see the little kids going door to door to report this, but also to educate people, but to dump out the water. So I'm waiting for that in Missoula.
So yeah, you've got very poor people, paying to, they're not necessarily waiting for outside, savior, but both of and you've got puddle patrol, even with kids. Yeah. Both of those are preventative. Say someone was already infected, what options, if any, did they have for health care? What's the how do you get help if you're sick?
So in villages, if you're lucky, actually for several villages, maybe about 8 or 10 villages, they'll have a public health station that is manned sometimes by a nurse, a person with a nurse education, but more often by someone who has a 2-year public health training. And so, but they still call them doctor, even if they have the 2-year training. And so you would go there for triage, and they have the decision trees to kind of decide whether you need to be forwarded on to the next level. Then you could go to the county level, and from the county level, if they can't help you, because even in the county hospital, very often there's only one doctor, and they're not very well paid by the government, so very often they'll show up at the hospital only 2 days a year, 2 days a month, and the rest of the time they're in their private practice somewhere else, making money. So you stop there, there's no doctor, you could be triaged to the provincial hospital, theoretically from the provincial hospital to the regional hospital and so forth. So you could get some care. It would be free or very low cost care, maybe only 85 cents, but can you afford the transportation to get to all these places in the meantime is another question. Yeah.
I want to get back into a lot of the things you raised, but I want to go to Joel for a minute to sort of zoom out all the way from this village setting to fancy important buildings like the headquarters of the Centers for Disease Control in Atlanta or the World Health Organization in Geneva, where a lot of the macro level policy or scientific decision making is made. Just sort of how they respond and even communicate these epidemics, as Chris was saying, to the BBC and then to us. So before Zika, the big new international infectious disease worry was the Ebola virus. Mm-hmm. In brief, what's the story of how do global health authorities respond to that outbreak?
Yeah, and it's interesting because it's not one story, it's a collection of stories. And I was just at a conference, International Risk and Crisis Conference in Florida, and there were people from the CDC and WHO and people from different countries presenting. And our research focused really on U.S. health organizations and how dealing with Ebola, indeed just the risk of Ebola, changed the way health organizations were functioning in the U.S. But listening to their stories and with the research that I've done, this is really loud. Is that better?
Loud's good.
Is that better? Okay. What they looked at was that you had a multitude of organizations, and from a communication perspective, the CDC came in, especially into Liberia, looking at how originally organizations were independent, they were competing with each other for resources, some were interfering. The World Health Organization ended up, through their bureaucratic procedures, being a more political organization, really slowing down the entry of healthcare workers, preventing a real rapid response. And what they found is over time, as they began to get a handle on what was happening with Ebola, they shifted in the way they were working together as competition to coordination, where each organization is still a separate entity, and then gradually working into a process of collaboration. And what they've really been trying to do now, and still are working on in the Ebola-stricken areas, is in that series of going from pre-crisis, there's a crisis and you set up your capabilities, to enacting the crisis where things are crazy, you don't know exactly what's happening, things are shifting and changing. They would declare an area Ebola-free and then there would be another outbreak, or they would find a sexually transmitted case from somebody else. As that was shifting, the organizations were gradually getting more coordinated, and then they moved into that collaboration phase at the end where they really have a common goal and they've taken the time to collectively get together. And so they're really working on capacity building and being prepared for the next outbreak. I'm not sure how that's going to translate to Zika because it's a very different outbreak. You dealt with a lot of contagion with Ebola, whereas with Zika, it's either through mosquito transmission, or it's through sexual transmission, or through blood transfusion, which is very different from Ebola. So that different crisis created a different set of needs. And the last thing that I've seen is the World Health Organization is making an attempt to change and reform, and they've put $100 million, which is not that much, toward having a rapid response team to cut through their own bureaucracy so they can better participate in those kinds of systems. But the World Health Organization is always limited by the fact that they're a part of the UN and they're beholden to a lot of stakeholders, as opposed to the CDC, which right now is beholden to Congress to try to get their $1.9 billion that they want. They're diverting Ebola funds to Zika, but they really want to move. They have a clear mission and they're able to mobilize quite quickly. And they already have massively, even back when I was at the conference, the CDC people said they were all over Puerto Rico, and they were, checking to see what was happening in Puerto Rico then. And I think a lot of that foreground work and pre-crisis work in Puerto Rico is paying off now that we're seeing the crisis is going to be bigger.
This is such an interesting communications issue, and obviously communications is a broad word, which is great that we have a department to this broad topic. There's that euphemism, a failure of what we have here is a failure to communicate. I think about, even here locally, Ebola did come to Missoula in a way because St. Patrick's Hospital was designated as one of the very few top-tier national isolation centers in the country. How did a Montana hospital make that list, and what was the immediate and long-term response?
Well, it's an interesting case. We actually talked about that in the last paper I did with a couple of co-researchers from Southern Mississippi and from Hofstra. The Missoula and St. Pat's in particular really touted their facility that they have as a result of their connection to the Rocky Mountain Labs. And it is a great facility, right? And they showed how well they can handle an Ebola case and how well they can isolate a patient and deal with them properly. And then that created a reaction in people. And when we talk about risk from a communication perspective, it's not just a one-way message to a receiver. That is, we co-construct meanings together as we enact as people, and it changes over time as people experience risk differently. And it was, in some ways, reassuring, I think, for the public that we have this great place here. But then people might send an Ebola patient
We don't want that.
to Missoula, and we don't want their kind around here, right, in that sense from a disease perspective. And so St. Pat's changed their policy somewhat. They came out with the next news story that said, we're here as part of our contract with Rocky Mountain Labs to deal with an infection, and if a local infection of Ebola were to arise, we will happily deal with that, but we will not import Ebola into Missoula. And suddenly Missoula, for the Missoula community, Ebola felt a little bit closer. And that changes over time the way you think about risks. Your exposure to risk and how other people react to risk changes the way you think about it.
Yeah, I mean, I was thinking, again, just this does seem to come up, and then we forget about it, and then we do the game again. And so, the WHO was accused of underreacting to Ebola. Just a few years before, they were accused of overreacting to the threat of avian bird flu, which, remember, killed Gwyneth Paltrow and half the world in that movie or whatever. And, can they win? Is this just a PR game? How do people get a grip on what's really risky?
Yeah, and I think, that's where there are a lot of different definitions of risk. A lot of times we want to talk about risk as an objective thing, which is the probability and the potential outcome. There are a lot of other definitions of risk that really get at the way we interact with risk. And the meaning of risk is really communicatively enacted. And so there are a lot of definitions, but one of them that I really like that comes from my colleague Steve Vanette at Southern Mississippi that he uses at times is it's the intersection of control and dread. Right? That what we dread in different ways is in part based on the way we see probabilities of the likelihood of something happening, and if something happens, what is that? And the other side of that is our control. And so I think for WHO, they have internal risks as a political organization, so they're always going to suffer a little more than other organizations. Like I said before, I think for people in general to think about risk, the important thing, and the CDC, and even I looked today at the World Health Organization website, their advice is mostly geared toward organizations and how should you communicate risk. And they really are following the best practices of our field and they have kits set up for organizations to use for how to communicate risk, how you should be upfront. You need to be very clear. You need to collaborate on common messages across groups in the same community. You also need to give efficacy. What can people do? We usually break those down into must, should, and may. And the things you must do to protect yourself, apparently at LAX is don't get bit by a mosquito.
Yeah.
Right? And then you're fine.
Worked for me.
Yeah, did it? You think?
I don't
you
know.
Don't know.
Steve's going to tell me later.
But that's what risk communication really is, and that's what we study is how does meaning evolve over time, the way people interact, and how can places like the CDC or organizations get involved in a way where they're helping direct a message in a way that's meaningful to people and can cause the best reaction.
So, what was the phrase? The intersection of control and
Dread.
control. Yes. Think of that at your next faculty meeting. So
It applies to a lot of situations,
yeah,
right?
Yeah, it's useful. It's useful. It doesn't have that Lux e Veritas ring, but if we translate it into Latin. So I wanted to, we actually have a bonus expert, Dr. Marshall Bloom from the Rocky Mountain Laboratory, and I was hoping I was going to do sort of a broader questions to the panel. I was hoping you might be able to join us, or if and as you wish. But I feel like this is my my Donahue surprise or whatever, my Maury Povich surprise guest moment. But I do have a bonus chair, so.
But not a bonus mic.
No.
Wow. So Brazil, where a lot of these new Zika cases are coming from, is the 5th largest country in the world. both in terms of geographic area and total population. Now people there are getting advice as dramatic as don't have children for the next 2 years while we figure this out. When you hear that, how do you respond? And kind of raise your hand if you want to take it or just sort of talk one by one.
You say bullshit. I mean, I don't know what the Portuguese word for it is, but I'm sure it's, I mean, it's a really interesting phenomena. I mean, it's in a country, in a part of the world, where women's health issues and reproductive rights are barely on anybody's radar screen. And so the access to contraception and the access to women's health and things are almost non-existent in some of these places.
Oh, I'm going to have to disagree with that. And can you show a
Oh.
slide that's called Total
Okay.
Fertility Rate and Contraceptive Use in 2015? I wanted to show you the figure for Latin America and Central America in general, and then also show just a couple of different countries. So surprisingly, our perception may be that Latin America, oh, it's Catholic, they won't be using contraceptives, but their total fertility rate in 2015 as the region as a whole was 2.1, which is replacement level. That suggests to me that they've been using contraceptives for quite a long time. In fact, modern contraceptive use is about 67% of married women aged 15 to 49. And look at the comparison to the U.S., which is only, our contraceptive prevalence rate is just 1 point above that, 68%. Our total fertility rate is a little bit lower, 1.9. Look at Brazil, 1.8, well below replacement level. They've been using contraceptives, and it's been permitted there in, with national policies since the 80s. So, very, very popular. And so, sorry, Pope, you may be worried about this and you're going to free them up to use contraceptives, but they've already been doing it.
Well, this is terrific because that's not the message which you see from reading the.
Yeah.
Right.
Yeah, so I wanted to share those
Yeah.
I love
demography
it.
statistics. Yeah.
I told my cousin I was moderating a panel. He said, if you can get them to argue and it'll play itself out. Yeah. So,
Well, and he actually didn't say contraceptives were okay, right? He said it was the lesser of two evils between choosing between that and abortion, and that
And abortion
there's
is
a
like
bit
a
of history
mafia,
of that in
right? So-
Catholic theology, right,
Yeah,
where
yeah.
you can do something if it isn't if it's an expected consequence, but it's not intended. Liking to study risk messages, I was really curious of what he actually said, and he referenced, was it Paul the? I don't get my numbers right.
Paul the
I'm not
Sixth.
I taught Catholic school
Paul
for
the
1 year.
Sixth.
Paul the Sixth.
I think.
His message was was really about nuns who were being exposed to sexual violence, and that using contraceptives was the lesser of two evils because it was intended for the purpose of avoiding STDs and pregnancy from sexual violence. So in that case, it was the lesser of two evils. And that's not really a ringing endorsement, but it's good to hear that.
But it's an interesting statement. Some feminists have really jumped on that. It's like, oh, great, this is going to free things up. But if you look at it historically and at the statistics, well, sorry,
Yeah.
they're not very good Catholics, or they've been going to confession a lot. I don't know.
It's a different version of good.
Yeah.
So do you see, and can you think of an example? I mean, I'm thinking about this maybe, well, I'll just ask the question. What does a disease outbreak like this reveal about a society's underlying culture and power structure? Are we noticing what's under the hood and we were wrong? Or is it actually, in other words, these stats are there and they've been there and we just haven't noticed them until we looked? Or is something like this have the potential to change a society and change a power structure?
I don't know. I think that's a terrific question. It's going to be really interesting. And in this country, the parts of the country which are likely to be impacted are those along the Gulf coastal regions. And I don't know, those numbers may be, I'd like to know what the numbers from Mississippi are, or Alabama, but I mean, those are areas where women's health rights are actually being suppressed in this country. And so those are the areas which are going to be impacted. And I know early on in Texas, there were some women's health advocacy groups who were really using this as and I can't remember, I'm not sure it was Planned Parenthood, but there were other groups that were saying, listen, you're denying women reproductive health and stuff like this. This is going to be a big problem. trying to use Zika as, as a lever to try to move towards what a lot of people would consider a more progressive attitude towards women's health and reproductive freedom. Would you agree with that?
Yeah, that would be an interesting move if that could
Yeah.
actually take place. And we'll have to kind of
Yeah.
follow maybe locality by locality or region by region to see
Yeah.
if that helps. I do think that some of the countries have been taking some steps in figuring out how much extra contraceptives they might need if suddenly the remaining, 33 or 43 or whatever, 40% might suddenly start using, modern contraceptives. But that sounds like a good idea. They're doing that in Puerto Rico already, and other parts probably should be thinking about that because, if you have a big demand and this is not there, I mean, you need to think about supply chains and working that out so that you can have supplies available when people have demand.
And I think that can change, whether temporarily or for a long time. I'm thinking about for Ebola, there are some people studying why did Ebola not really take hold in Nigeria, the most populated country in that region of Africa, if not in the whole of Africa. And they're looking at the way the health workers worked with local leaders and how people even gave up a lot of common cultural practices for a period of time. It's a very touching, common, like a very Christian, common cup for communion kind of community, a lot of hugging, a lot of close contact, and how they involved local leaders in the process of stopping that for a while, saying we need to not do that for fear of Ebola. And people were willing to in that notion of what can you control, but having a good meaning behind why are we stopping this cultural practice? What could this help us do? So, I mean, there's a possibility, but it depends on where it gets enacted.
It's another question, why just tell people not to get pregnant? Why not say, well, start using repellent? And, if you're going to have any sort of sex with your male partner, use a condom during the whole pregnancy. I mean, you didn't have to not get pregnant. There are ways to protect the pregnancy that, don't involve, not even having it.
Go ahead.
Is there a concern? Are you having a mic issue or anything? I just heard a murmur. I wasn't sure. As long as you can hear.
We have 5 young girls that have been nannies in our family, and I'm friends with them on Facebook, where there's a lot of conversation going on. It's in social media in Brazil,
Yeah.
and the young ladies are really, they're on the issue way more than the statistics might suggest. Social media leaders is that good.
Yeah. Well, maybe people are communicating and knowledge is being transmitted.
And most tweets are retweets, and that's where, with use of social media, getting involved early and having an effectively written message that has, is clearly stated with a threat and followed very quickly with what you can do, and then later having clear action steps as part of when you're limited to 128 characters, what you can do is interesting research. But there's also a tale of 2 Brazils, it seems, in the sense that people who are more urban and have access to cell phones, and then other communities. We were talking to a professor, we were thinking at this conference, we were looking at doing a project, pairing with a professor in Brazil and looking at the community differences. And one of the things they brought up is there are communities where they only have access to water once every 4 days. So standing water is a survival technique. So to what extent do they, get covers for that water? Do they change the way they keep water? Do people in that community have access to contraceptives at the same level that people who are in more, in Sao Paulo or somewhere else have access? Is a real big question. And where are women's rights in one community versus another, I think is a really important issue to look at.
I was thinking about the dangers of social media, the possible dangers of social media, because there have been a lot of rumors circulating on social media that microcephaly is caused by Monsanto, and there's a particular pesticide that that social media will claim is causing this microcephaly.
Or a vaccine.
Not
I saw,
Zika, right?
also
So I
vaccination.
mean, those rumors that are kind of scary can get spread,
Yeah.
but then then the public health workers and CDC and World Health Organization have to try to act against those crazy myths.
And in social media world, that's why it's important to get the correct message out first.
Yeah,
Because
yes.
pardon the expression, is going to go viral.
Yeah.
And, you know, and it's going to get tweeted and retweeted and everything else. And
Yep.
so, and it was like
Yeah.
one of the guys at the Mansfield Center said, quoting Mark Twain, he said, "Lie can travel halfway around the world before the truth can get its shoes on."
Yeah.
And so
Yeah,
I think the
yeah.
CDC has recognized that.
Yeah.
And their communication in this, I think, has been really good. And I think the World Health Organization done a way better job than they did with Ebola.
Yeah, I'll get the phrases wrong, but one of the best practices is be first, be right, be consistent, right? And so getting that message out early is there. The CDC, and even for other things like disasters, now disaster organizations of different kinds have to monitor social media, and then they have to make a decision. Do we counter it? I know the earthquake people that I work with have a problem with that it's always that they knew ahead of time but didn't want to cause a panic, and they're going to deny it, which then as soon as they put out a denial, that's not true, the conspiracy theorists say, yep, see, we told you they'd deny it. This is proof we were right. But the CDC does, for example, in local ministries of health, decide which messages they should counter and which ones they shouldn't, but they don't always know which ones to do. And, you know, and how do they get a counter message out there?
I want to ask just a couple quick questions for you to make sure we have time for, you know, I really liked, you know, that addition. I want to hear more from the audience. If you have any questions of your own you want to put out there before we close. But I guess one question is, do you think Zika will make it to the United States and Missoula? Why or why not?
Well, I think we can take a little bit of comfort in, for example, dengue has been sort of knocking on the door for quite a long time, and it has not made significant inroads into mainland U.S., and it's carried by the same genus of mosquitoes. And this genus of mosquitoes is not comfortable way up here in Missoula. It really likes a warmer habitat, so I think until it gets a lot warmer up here, we're unlikely to see it this far north. I think it's unclear right now which mosquitoes will be capable of carrying Zika. The virus that I work on, Rift Valley fever virus, is carried by Aedes mosquitoes, Culex mosquitoes, and Anopheles mosquitoes, and we have some of those species around here, so it seems that some of these viruses are opportunistic in what vector that they'll use. So if it jumps and uses a different vector, it might come up here. But for the time being, I don't think we have to worry about it up here.
But there are cases in the U.S., so 358 as of today. And there's been one in Montana, and actually it was in Missoula. These are not cases that are being transmitted by mosquitoes here in the U.S. They're travel-infected cases, or a few of them are actually sexually transmitted cases, because we do at least know that the disease stays active longer in male semen than it does in the blood supply. So thus the using condoms when you're having sex. But so it's not like a widespread transmission, sort of thing right now. But we have had these traveler cases.
That's true. I think that's right. And this virus has been shown to be transmitted, as one of you said, both by mosquitoes, definitely by sexual transmission, by blood products, and then also from mother to baby, which is the one that leads to the birth defects. And everybody said, well, and in the experimental models in mice, which have been looked at so far, the highest concentration of this, and these are mice who get neurological disease, the highest concentration of virus is actually in the testicle of the male mice, higher than in the brain. And so sexual transmission and the virus has also been identified in the urine of people who are infected. Whether that means it's transmissible that way or not isn't clear. And people say, well, how come they didn't realize that before? Well, if you have a place like Yap or Recife or something like that, where 100,000 people are being bitten by mosquitoes, you're not going to see, and somebody else gets sick, you can say, well, I don't think I was bitten by a mosquito. Well, obviously, everybody's been bitten by mosquitoes. It's only where you get to a place like the United States where mosquito avoidance is possible that cases of transmission by blood transfusion and venereally. And there was a case today showing it can be spread by anal intercourse.
And oral
So
sex.
there was the first documented case of male-to-male sexual transmission, just reported today in MMWR. So, I mean, you're going to see these things when you take away the large preponderance of cases which are vector-borne, mosquito-borne.
So I'm going to make it slightly more personal. If you had the chance to go to this year's Summer Olympics in Rio, would you?
So
and what if a friend who was pregnant asked if she could come with you?
There are two things I would say. One would be www.cdc.gov. And see what they said.
That stands for what would the CDC do?
Well, that's where you want. That's where you're going to get your information.
Okay.
But the other thing is that the Olympics in Brazil are August 5th through 21st. Now that's summer here, but it's not the height of mosquito season in Brazil. And if there was a group of Italians that did a study of a dengue outbreak which occurred there a few years ago, and the peak of Aedes mosquitoes was, I think, like January to March or something like that. And the peak of the dengue cases as a result were like in May, so which are like 4 months ahead of when the Olympics are going on. So the feeling is, and certainly there have already been a huge number of world-class athletes who say, I don't care, I ain't going anyway. You need to cancel it and blah, 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 and blah, blah, blah. But it looks as though the risk is going to be out of sync. The predominant risk is going to be out of sync with the predominant season where the mosquitoes are going to be active. Would you agree? Would you?
Yeah.
Yeah.
So
I mean,
I
don't
take
know
this
if that's
ticket out of my pocket. You want it?
the ticket.
You'll
I'll
go.
take it.
You'll go.
Probably.
All right. We got one yes.
Yeah. I'm
Two.
trying to get there
Can you
now.
show the beautiful slide of the pregnant woman in her outfit? So I would go, and this is what I would suggest you to wear, if you can lower the lights. But yeah, it's her mosquito net with an umbrella. So she's protecting it against rain and against mosquitoes. And I would advise putting repellent on underneath the net too. But yeah, why not? And you know, if you're old enough, I'm no longer able to be pregnant, and I don't have a partner. Why not?
Yeah.
Give it up.
All right.
I'm going.
Yeah.
The recommendations are for women not at present. The recommendations are not to go.
But women of childbearing age.
Women of
I'm too old.
childbearing age, and if you're a man of whatever
A partner of a woman of
partner of a
childbearing
woman of
age.
childbearing age, those recommendations are to refrain from, sexual intercourse. But man, it's like I said, it's a moving target. The advice changes and things like that. I mean, before the Ebola outbreak, wasn't really appreciated that a venereal transmission was possible. So.
Steve, you going?
I would go.
All right.
Let's all go.
But
We're going.
yeah.
Thank you all. We're going to go right now. I think
That'd
we
be
just
great.
got to acclimate. We don't want to just go there and just sort of faint in the humidity or anything. I think. Well, I guess we'll do this probably again. But could you? I just want to start before can we give this panel a wonderful round of applause?
And to you, Marshall.
Yes. And now anytime, if you ever see me moderating, I could just pull you out of the crowd and put you on the panel. So
No one is
be
safe.
ready. I think we've got time for just like 2-3 more. If anybody wants to ask a kind of question, or if anybody else is an expert in this area that we've been hiding, love to hear about it.
Do we have any idea how long an infected person may carry the virus, and how late or in a pregnancy would it be safe to get infected? In other words, to avoid microcephaly. Do we have any idea?
Well, no, the short answer is no. It seems that the highest period of risk for the babies is probably thought to be between like 11 and 17 weeks. The microcephaly is now recognized as being of two sorts. There seems to be one sort where the baby the fetus becomes infected as the brain is developing, in which case the brain doesn't develop. This virus infects nerves and it kills them, neuronal cells, and it kills them. So those are babies that are born, if they're born with microcephaly, and the tops of their heads are smooth. There's another pattern, which is seen, which is thought to be the result of babies being infected as late as like 17 or 18 weeks. Those are cases where the skull has developed a little bit and the brain has developed a little bit. The fetus gets infected, the brain basically disappears. The skull becomes microcephalic, and the skin on the scalp is rugose. It's got folds. That, if a baby is born with that condition, that's very, very obvious. In the one case of women who were studied in the U.S. by the CDC after they came back from Brazil, it's about 15 or so women. 2 of those had miscarriages. One of them had a baby, and I might get this a little bit wrong. One of them had a baby with severe microcephaly. One of them had an apparently healthy baby, and the other ones were being followed. But being apparently healthy at the time you're born, if you were infected at this late with this virus later on, doesn't mean you might not have developmental abnormalities or other issues later on. So I think it's going to be an open. That's what makes it so scary. Were it not for this fact, this would be, like I said yesterday, classified as a real junior varsity virus. 80% of as Steve said, 80% of the people don't know they're infected. So, but the spectrum of neurological diseases being associated with it is really astounding, way out of proportion to the severity of the infection. So I think it's going to be a big learning curve.
Yeah.
No, I agree.
I think the other part of that is that translates into uncertainty, right? And different people will manage that in different ways, because if 80% of people don't know they're infected, we really still have no certainty about where the disease is. And we also don't know all of the impacts, and it's most likely only going to get worse. You know, part of me was thinking when the CDC came out and definitely said it caused microcephaly, wow, that's a big change. But I think for a lot of people thinking about, are they going to go to the Olympics, countries working on what are, Puerto Rico thinking about what are the social impacts, that really doesn't make much of a change because they're already dealing with that same level of dread. But I think uncertainty increases that dread factor. So not knowing, I personally want to be more safe. Some people use that to pretend like it's not happening. And that's, people manage the fear instead of managing the threat. And that's a common human reaction.
We had another question over here.
Yeah, maybe for Steve or Marshall perhaps. Why are we seeing this just burst on the scene? Has it reached some critical population all of a sudden, or has it evolved into a more pathological virus than it was a year ago or 10 years ago?
Yeah, that's exactly the kind of question I raised a little bit earlier. Those are the possibilities. One, that it was just below the radar before, and the reporting was poor, and so we didn't see some constellation of significant health problems that have now come to light under increased scrutiny. Or the virus has mutated a little bit and it's more pathogenic, or that the virus has reached a population that is more genetically or immunologically susceptible to the virus, and so that's why we're seeing this. So I know in Rift Valley fever virus, for example, in outbreaks in other regions of Africa or the Arabian Peninsula, the effects have been much more notable and dramatic than they were back when it was just in Kenya. And so it's still unclear whether that's a function of the virus having mutated or it's encountering a more susceptible population. Maybe Marshall knows more about
Some people think it was a real strong El Nino that created conditions way more conducive to the mosquitoes.
And this is
Yeah.
one of the strong El Nino years. So.
Yeah.
And did you not, tell me, I think in our earlier conversation, that climate change has really expanded the terrain and globalization as well as just sort of transportation?
I think we have time for one more question for now, but of course, people can meet with us one-on-one and I'll let you.
I find the fear factor is much higher when you go that it's really not so much the mosquito. I mean, the mosquito's really only for a pregnant woman or is going to get pregnant. If in fact it is a sexually transmitted disease, which is what it could be, and if you've now got, male on male, then you've also got this whole AIDS thing and it becomes sexually transmitted. Does that change how the public's going to look at it? I mean, how we've looked at AIDS from 30 years ago, that it was just a homosexual problem, to now it's, people are looking at it across the culture, how does that change the environment if in fact it's no longer just a mosquito-borne, but it's a sexually transmitted disease?
Well, the thing that makes AIDS and hepatitis B, which is also venereally transmitted, so bad, is that those are viruses which persist in the body of the infected person. And it's likely, although it hasn't been demonstrated, that most people, the work that's been done so far, suggests that people become infected with this virus. They may carry it for a while, but then they're going to get over it. They're going to get over the infection. And so I don't think this is going to become, my own opinion, I don't think this is going to become something like HIV. Venereal transmission is going to be one way of transmitting this, but I don't think it's going to become a predominant mode of transmission.
Yeah, and I think, the real answer is it's easier to look back and see how meanings of risk have changed over time, because, we really don't know, because we keep enacting the meaning of risk together. Does that, and so if we are enacting the meaning of risk together, how we proceed, what events sort of happen. Right now, the face of Zika are the microcephaly babies. And is there a new face? Do we find another neurological disorder that's connected to Zika? Which faces of Zika become more predominant? Is it something that isn't as prevalent in urban areas but is in very rural areas? How much does the media end up covering that and change our agenda? We really can't predict where that's going to go. We can help guide it along to be an informed process, counter misinformation, but really it's hard to predict.
I'm getting a call for one more question. I'm going to do it. Oh.
I think it was me.
No, here.
I grew up in the South and remember the trucks driving through our neighborhood spraying for mosquito control. So when we look at the control of Zika, you can't leave out the mosquitoes, right? And although it's not going to affect us here in Missoula, I just wonder, in terms of environmental health and mosquito control, we have multiple risks that we're balancing. And so what kind of information is coming out from CDC or WHO in terms of mosquito control?
The stuff I saw from, sorry, jumped in right away.
I was handing you the mic.
Oh, I've got this one. I got a micro mic.
Yeah.
What they were saying is they're really trying to take an approach that is a localized neighborhood-based approach in Puerto Rico, because mosquitoes in different regions are susceptible to different agents for controlling mosquitoes. So they're finding they can't even have a national program of mosquito elimination or minimization, that they have to do that locally, but they're trying to tie that into finding local leaders to also educate and inform people and provide access to mosquito repellents. But in poor neighborhoods, that's kind of tough. And so as they get more resources, they're really taking a neighborhood by neighborhood approach, which I think is smart, both from the biological side, but from the social side. That's what really helped in Nigeria with Ebola, was local leaders also explaining why they should change practices and people mutually reinforcing that with each other.
And I think one of the points I was going to bring up is, I'm not as worried about the U.S. because we spend so much per person on healthcare and public health, and we have a very good system. But it gets a little bit scarier when you look at a country like Haiti, for instance, that has an annual per person health budget of $77 per year. That's for every disease, for all the hospitals, all the doctors, vaccines. That's scary to me. Then how do they, in that tiny budget, squeeze out some more money to, deal with mosquito repellent and bed nets and, stuff like that. So I think depending on the country, the response is going to have to be, either dependent on some international aid that can fund some of the spraying or bed nets, or, I don't know that it can even come locally.
There's also a very interesting, I'm not an expert on it, but an interesting approach by releasing genetically modified mosquitoes that when they mate, they cause all of the eggs after mating to be inviable, or the mosquitoes after they hatch, they die before they're of breeding age. And there have been some field tests of this technology And it has some pretty good results, but it's not without controversy because you're releasing a genetically modified animal into the wild. So, but I imagine this is going to spur some more discussion about this topic in the cost-benefit analysis.
All right, we're all ready to write our science fiction novel. It's going to be true, though, it seems. Go to the Olympics, then come back and stay here at the University of Montana, where it's safe for the time being. And yeah, can we again thank this panel for their... Thank you to the college for hosting, and thank you all for coming. And
Feel free to mingle, talk to us one-on-one.
if you want a copy of the book, I'll be outside.
Thanks, Jeremy.
Yeah, thanks so much. It was terrific.